Welcome and thanks for joining us for today's HIS Talk webinar, Care Team Coordination, How People, Process, and Technology Impact Patient Transitions. It's brought to you by Zinx Health. I'm Lori from HIS Talk and I'll be moderating today. I have a few housekeeping items to make you aware of before we get started. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit your questions to our presenters at any time. The presenters will answer your questions during Q&A. Today's webinar is being recorded, so you'll receive links to the recording as well as a PDF version of the PowerPoint presentation. We have two speakers today. First up will be Grant Campbell. Grant is the Senior Director of Nursing Strategy at Zinx Health. Joining Grant will be Shiva Subramanian, who is the Senior VP of Mobile Products at Zinx Health. And with that, I'll turn it over to you, Grant.
Thank you, and welcome to all of you this morning. In order to get the HIS Talk presentation started, I'd like to share some learning objectives. First off, help you better understand organization-wide how people, processes, and technology all support one another in terms of care team coordination. Ways to leverage the expanding role of care managers and other disciplines who participate in care management or care transitions. Looking at ways to incorporate best practices and complex care management models into a transition process, as well as the use of evidence-based care transition content. And then by way of case study, look at how organizations have impacted such things as 30-day readmission rates, length of stay, as well as high-risk referrals of patients to post-discharge programs. So we'd like to start with a polling question. So, first off, for the group, what is the result of a poor care transition? You can select one of the following: adverse patient outcome, reduced efficiency, penalties, or all of the above. And we'll wait for a moment here while the attendees poll. And all of you score 100%, and yes, it is all of the above. And typically now today, we think of poor care transitions as being primarily having financial impact, but in reality, the impact is much broader and extensive beyond that. So let's move to our second polling question. So, what of the below actions would have the greatest impact on improving care transitions at your organization? Connecting teams, simplifying processes, or providing a secure communication solution? And you can see that the majority of respondents are really very much concerned in terms of connecting diverse care teams. And this is very typical of what we see in the industry or in the clinical practice environment nationwide. The reality is that our current mechanisms, whether it be our electronic health record model, our processes, our care delivery systems, really do not give us visibility and insight into those who are either directly or indirectly providing care for that patient, regardless of where they are in the continuum. Let's move to our final and third polling question. What percentage of serious medical errors do you believe involve miscommunication between caregivers and when patients are transferred or handed off? Please select one of the following. And the correct answer is, in fact, 80%, which 45 of you got. I think it's always very interesting to individuals who see this statistic for the first time that when we talk about serious medical errors, it's actually the transition moment between clinicians, either within a discipline such as nurse to nurse, or across disciplines, say nurse to physician, that when this handoff occurs, that the likelihood of a serious medical error occurring increase exponentially. And this is greatly related to our reliance on memory-based care, as well as outmoded or legacy models for care communication and coordination, which we'll touch on briefly today. So now we'll move it directly into our theoretical component, and we'd like to share this first off, what is really critical to those managing care transitions? Now today there are as many definitions of population health as there are populations, but in reality, whether you are an acute care provider or a post-acute or community provider, being able to improve disease management, community, health of the community, and populations overall is really a key guiding principle behind those managing care transitions. We know that there has been great difficulty in terms of providing seamless, safe, efficient, effective mechanisms to support transition from the acute to the post-acute environment, including communicating about a person and or their family needs, as well as the coordination of care. And this can include, of course, when one moves from the four walls of the hospital into the community setting, perhaps in a post-acute environment such as a skilled nursing facility, or even to their home environment with self-care and management through their primary care provider. How does one ensure that key components of an individual's decision about their health or their family's decision about their health needs continue to stay with them? We clearly want to have a measurable impact on admission, readmission risk reduction, and identification and care transition barriers. When I say measurable impact, a way in which to actually be able to collect what we consider to be valid and reliable data around these elements as well. And really, looking in terms of care transition barriers, what can we identify from the evidence now today that helps us risk stratify and or measure what is actually impacting these transitions to another level of care? Clearly, all organizations as well as programs are looking at optimizing resource utilization to improve outcomes and cost savings. And then on top of that, how can we use technology available now today, such as mobile platforms for care coordination, in a real-time model? Those of you who work with current electronic health record systems know that there are limitations in terms of the robustness of real-time communication. There are limitations in terms of how one accesses or is visible in the system. And so, we in our personal lives rely on mobile platforms for real-time communication. How can that same technology be harnessed for use within the clinical practice environment that those of us work in? And then finally, how does one securely message within or across groups, teams, individuals about the care transition or care coordination needs of a particular person or their family, as well as, and this is a significant impact to physicians and nurses, reducing nuisance interruptions in care. So in other words, that routine reliance on pagers, faxes, telephone calls, et cetera, that may actually impact the quality of patient care. Can there be a way to better support care coordination through other technology applications? I don't have to probably remind many of you that the shifting healthcare landscape is upon us, whether it's values-based purchasing, accountable care, changes in legislation related to CMS, reimbursements for Medicare and Medicaid. The old model, which is clearly delineated on the left-hand side, is now transitioning to the new model, clearly providing value, being much more efficient and effective at coordinating care within and across disciplines, both within the four walls of the hospital as well as outside. That this care coordination is really goal-oriented, and not goal-oriented at the clinician level, but goal-oriented at the person and family level. In other words, for those of you who may be familiar with such things as patient activation measures or motivational interviewing, the reality is now today, how we best coordinate care is by understanding what a person and their family want and are capable of achieving. And that the physician is no longer the decision maker, but rather provides overall coaching and support to the team, and that in lieu of task-oriented nursing care, we're really looking at a broader approach to care management, assuring that the right resources and programs and services are made available to a person and their family at the moment in time that we are touching them in the care coordination and continuity of care model. So how do we coordinate care for high-risk populations? And what we've got here is a simple pictogram that says, at minimum, we need to identify target patient populations or target populations themselves. So the reality is that there's many individuals out there who receive care. They can be stratified into a variety of different levels. And you can see by showing the image in here, sort of a two-tone color, that really within a overall or broader group of patients or a population, there are a certain number or subset of those individuals that truly are at risk for a particular phenomenon, readmission, safety, whatever the case may be, and that at the end of the day, we need a mechanism to identify these target patients and bring them deeper into the care coordination model. At that point, we can assess those individuals for risks and barriers, and here we've identified 3 that are well documented in the evidence. Their risk of falls, they need safety intervention, they have no PCP, or they have limited or no access to insurance. And so what happens at this point then is we need to clearly delineate what resources do they need, what people provide those resources, and what are the evidence-based interventions associated with making those people and resources more effective, efficient, and able to solve or resolve issues for this person and their family. And so that ultimately, we then have a real-time communication and evidence-based plan that supports their transition either from a venue, such as the hospital, to a post-acute venue, such as a skilled nursing facility, or from a venue to potentially self-care management at home with their primary care physician and perhaps even our home health services in place. So that being said, what do we know about what are the barriers to effective care coordination? And they really fall into 3 broad but distinctively overlapping concepts. And the first is the teams themselves. Despite our best effort, we continue to, in essence, force a model of silo-based care. And it's not that we want to work in silos, but there are barriers to, in essence, cross-communicating, so to speak, in terms of what various care teams are doing. We know that teams are mobile and diverse. They're dispersed across the care setting. While nurses may work with a certain population of patients on a unit, a hospitalist or an intensivist physician model means that they're working across multiple units. We may not have deep visibility into what each and every member of the care team is doing, which leads to duplication in services and or individuals who in essence fall through the cracks because one group thinks that the other group is doing something. And that we then, of course, because we work in silos, we lack this cross-communication or coordination. The second piece on the right-hand bottom bubble is this care transitions and discharge process. Many of you are involved rather in Six Sigma or Lean or other performance improvement methodologies, and you know that process workflow mapping is critical to understanding where we have barriers and risks or threats to patient safety. And one of the elements that we know has not been perhaps as well documented is what is exactly the process associated with patient handoffs. We're not talking about potentially a simple handoff one-to-one, but the fact that we have multiple and complex handoffs occurring, as I said, within disciplines and across disciplines and across settings. We also are not necessarily deploying evidence-based practice in terms of care transitions. The phenomenon of using evidence-based content for care management in the acute inpatient setting, whether it's physicians, nurses, physical therapists, has been ongoing now for many years. The reality is that there is a significant body of evidence that supports care management and care transitions, and the question is now, how are we actively employing or deploying that evidence in our practice? And once again, like anything else, it can be very difficult to standardize processes and gain consensus around, essentially what does a standardized handoff workflow model look like. The last one is communication. How does one align care team members around the concepts of the patient plan, risks and barriers to discharge, and then see real time exactly what are we doing to A, mitigate risks, and B, manage barriers to discharge or transition. And so this communication mechanism becomes critical because now today, and I would suggest that this is true of any electronic health record model, whether it's inpatient or ambulatory, it's very difficult to see at a glance, A, who's looking after this person, B, what is the overall plan, and C, for those things that we do know are risks or barriers, what is the actual mechanism or what interventions are we deploying to actually address those concepts? So at the end of the day, this somewhat simplified Venn diagram says, what is the sweet spot in the middle there that then helps us manage this phenomenon? So this is the current state. Our poor patient in red over here with his family members associated with him, we'd like to think that in this patient and family-centered care model, they are at the center, but the reality is that, as you can see here, the mechanisms by which we communicate either with the person and their family or about them within and across disciplines is essentially, for lack of a better word, discoordinated, if such a thing can possibly exist, and that we have multiple dotted lines here as well as disconnect between various members of the team. In a perfect world, we like to migrate to the future state. And the optimal state would be our patient now in green, so well known to us, being able to communicate with us about his or her needs, their family equally involved in their care, and those individuals who are both directly or indirectly involved in their care, now in essence centered around this particular individual and their family, and using a mechanism that allows for clarity in terms of the plan. And you'll notice I've used the term both direct and indirect. And the beauty of these types of care coordination models is that they need to be able to support the fact that an individual may be involved in the care of a person and their family, but may not be actively involved at a particular point in time. For example, in this model here, say for example we admit Larry Smith with an exacerbation of his heart failure. He's actually seen by a coach in the community as well as an ACO care manager. Well, they may not be actively involved in his care while he's being treated in the four walls of the hospital. They do need to have visibility into the plan for Larry as he transitions home. And so once again, in a perfect or optimal state, everyone who touches Larry in his journey across the continuum needs to have visibility into the plan depending upon where he is at any particular point in time. So sharing with you a case study from a Northern California ACO, you can see on the left-hand side the demographics of this particular ACO. It's a Medicare shared savings plan, physician-owned, and with significant number of beneficiaries here. And what is very unique to them, and this will come back when we share more details about the case study, is that the sheer size of their service area, 2,600 square miles is a significant amount of space for a care delivery team that you see delineated below to be able to coordinate care. And you can see that in their transition goals, they really need to improve the mechanism to transition patients from inpatient to outpatient or skilled nursing. They clearly wanted to prevent avoidable readmissions, and we know that there are unavoidable readmissions, and we need to be able to stratify those. We wanted to improve patient safety by better understanding the disconnect between the discharge medications, the actual medications, and therefore medication reconciliation, and clearly improve patient family satisfaction. And so how were they able to do that? Well, they really looked at creating a high-quality collaborative care management model. At the highest level, they wanted to be able to integrate into their care management model evidence-based content. So practice guidelines that specifically are hardwired into their care delivery model that are based upon evidence and can be therefore measured in terms of efficacy. They also wanted to be able to connect providers to form cross-continuum teams. And what that meant is, across the entire care navigation network, what is the mechanism by which all individuals who touch this particular person and their family can in fact have visibility into the plan? And then the third piece was, can they have real-time context-specific messaging? And what we mean by context-specific is, rather than me messaging you and having to reiterate the entire story of the patient, can there be real-time contextual messaging essentially centered around this person and their family, so that every time we communicate within and across disciplines, from person to person or one to many across the team, that everyone sees it's within the context of this particular individual and their family. So the interdisciplinary team, and we won't spend much time here, but members and roles are evolving, and some are currently established versus others that are becoming more prevalent within the organizations, both inpatient settings and outpatient settings. We now have licensed versus non-licensed. In the past, typically we've seen discharge planning as being a very nurse-centric type of thing, with the physician writing discharge orders and then some series of activities occurring where someone then moves back out into the community. But the reality, we have now, community coaches coaches, who are non-licensed individuals who, in essence, provide direct care management or care support. You see that we also have direct versus indirect providers, and I shared that with you earlier, that depending upon the venue, the direct providers and the indirect providers may switch off. So if I'm in the hospital, a direct provider might be a nurse or a physician or a physical therapist or a pharmacist. An indirect provider might be that ACO coach or care manager who is visualizing the care of the patient. And then we also have operational versus organizational roles. So the people who actually deliver care directly and indirectly, those are the operational roles. And from an organizational standpoint, clinician leaders or organizational leaders want to have visibility into the care management or care delivery model. We also need to, in essence, connect care delivery. So within the settings themselves, we need to connect disciplines, physician to physician, nurse to nurse, physician to nurse, physician nurse to many on the team. We need to also be able to connect venues. So I move from the acute care to the critical care to the general care environment. But we also need to connect programs as well, or service offerings. I move from the hospital to my home with, say, palliative care or hospice. And so this interdisciplinary team has expanded exponentially. And here's an example of this ACO success model in terms of having a skilled case or care manager plus their skilled nursing facility partners to improve outcomes. And so by better coordinating or understanding the need of this person as they move to the SNF facility, we develop better family dynamics around the plan with and for this person, setting realistic goal. And by extension, one of the ahas for us in this ACO model was really having a deeper dialogue about end-of-life wishes known and documented, and then safer discharges or transitions, to the SNF or ultimately home environment, and all of this being achieved by having this patient-centered remote access communication model in place. So now today, the current state is, in terms of process mapping, it may be non-existent in many organizations. We have a sense of what is happening, and we don't necessarily know what the impact is of the care transition process on either safety, that's identifying risks, clinical effectiveness, are we achieving discharge readiness in a timely manner, and that's the efficiency. Are we able to move patients to the next level of care, in an expected date and time, or do we have delayed discharges and avoidable days? In future state, there are many evidence-based transition and care management models as well as content elements available in the literature. And now we also begin to look much deeper at the workflow associated with 3 different components. 1, when I move from acuity to acuity. 2, when I move from one venue to another, and 3, when the person who's leading the management or care of this patient changes, for example, hospitalist to a PCP. And so last but not least, combining all these elements together, looking at multi or interdisciplinary teams and evidence-based workflow, we have a mechanism by which an individual could be referred into a particular program or service or model. That could happen at a hospital or ED level by some selection or notification criteria, or a population health manager could make a person aware of or enroll them in a particular program. Once they're in that particular program and under the auspices of a care manager, we do assessments, identify goals and barriers, and these goals and barriers then help us to further delineate risk-based interventions that will help support those goals or barriers. Ultimately, we can stratify patients into risk levels with appropriate resources, including individuals associated with those, and from that would identify a team, one or many individuals within programs or services that can now support that particular individual's transition needs. And so this truly becomes a patient and family-centered care management model using people, processes to support care management. And so now I'm going to turn it over to my colleague, Shiva, to now take us through the third piece of the wheel, which is really the technology component.
Thank you, Grant. Hello, everyone, and thanks for the time today. Grant did an amazing job trying to highlight how the shifting landscape has now put a new model of care in front of organizations to go outside of their traditional walls of care, if you will, and reach out to other providers in that community to take care of patients as they cross these settings, to have a seamless, safe, and an efficient transition of care. In an environment where communication's already challenged, having this additional need for coordinating outside of walls, coordinating across a broader multidisciplinary team is only going to increase the challenges and the stress faced by healthcare providers all around in taking care of that patient. On top of that, the healthcare reform is also forcing the hands of various organizations to become more efficient, because the triple aim also requires reducing costs. So how can one take on more work, give more work to the providers and the care teams, while also becoming more efficient? That's a tough challenge unless you have the right information technology tools to help orchestrate and navigate this change. And what I'm going to talk to you today is about how mobile devices can play a very important role in this transformation of healthcare, driving better outcomes at lower costs and better healthcare for all. Mobile devices are often in the spotlight these days because of the challenges they pose to CIOs of especially hospital organizations. And the reason is very simple. Physicians who have a high need to communicate with the other members of the care team and with one another are starting to increasingly use their personal devices to text information about patients to other providers. Why? Because it's a very convenient and easy way to do so, provided you know who the other person you want to talk to is. While that may address a very short-term need, it does pose a risk to the organization in terms of information protection and HIPAA violations that could occur if they put information in those messages that are protected health information about the patients, because you never know who's at the other end reading those. Text messages sent via SMS are sent from a phone number to a phone number and have no mechanism to authenticate that the person receiving the message is actually the person who's authorized to receive that message. So while there is a demand for that capability, the risk that organizations face is if they allow this to go without supporting those care teams with better tools that are HIPAA compliant. You can look at the numbers, they are staggering. 90% of healthcare providers are already using smartphones in some way or the other in the workplace, and 57% of them send work-related messages. One can only hope that these were done in a HIPAA compliant manner, but there's no way to enforce that, at least not until you give them a better solution. It has benefits, so the question to us and to the healthcare provider organizations is, how do we reap those benefits and perhaps even improve on those while managing these risks? Let's take a look at why mobile devices are so compelling in the healthcare environment. And it has a lot to do with the power of smartphone and tablets and the technology features that they bring together, and what it means to healthcare and what it means to care of a particular patient. I've noted down a few. The list could actually be quite long, but these are some of the key ones here. Technology that fits in your hands and allows you to, at a glance, get a good representation of the information that you need to know is key. As we all know, EMRs are necessary tools to ensure we have solid documentation and regulatory compliance and billing. But EMRs have been built and added on over the year, and they may have 20, 30 tabs of information that one has to delve through in order to dig out what is important. That has a specific purpose and a use case, but getting information at a glance is clearly not one of the strong suites of those tools. So smartphones and tablets, on the other hand, can and are very much able to provide this type of a consolidated, condensed view without the intrusion of bringing a laptop screen or another screen in between the provider and the patient. Another key and very powerful capability is the the fact that these devices are today almost ubiquitous. They are in everyone's pocket or in everyone's hands. They're always on. You don't need to sit down and make a conscious decision to log in and look for information. Information is transmitted to everyone in real time. What that means is you could reach the right provider at the right time with almost zero delay. And when healthcare is looking for improvements in efficiency, this capability is very powerful. Hand in hand with that goes the capability of push notifications. As I mentioned, there is no need for a conscious decision for a provider to log into the EMR and say, hey, do I have any orders on this patient? They could be transmitted as an alert to that provider in a timely manner so that the right care is delivered in time, and that means significant efficiency gains. It means earlier discharges, it means better care, fewer drop balls. The simplicity of providing such information for a select set of use cases on a mobile app simply means that now you can expand the reach to people without having to wait for heavy IT deployment times, training times. When is the last time anybody read a manual to use a mobile phone? We have deployed solutions in the past that providers just take up the mobile device, download the app, and with a few swipes of the screen, touches a button, they are able to learn how to effectively utilize. That simplicity means a lot to be able to not only expand the access quickly to bring in as many providers as possible, but also to extend the reach to patients and their family, especially when there's a significant population in our country that are the aged population, right? So it has to be very, very simple for them to use. Last but not least, there is a growing trend and a growing wave of instant messaging usage across the globe with smartphones and tablets. Why not leverage that and ride that wave to provide that same instant access and efficient access to our healthcare where it is most needed? So what we've done is look at all the capabilities and the right use cases, because mobile devices don't make sense for everything, right? You wouldn't want to start using your smartphone with a 6-inch screen as an EMR. However, it has its place and has its capabilities that can significantly improve care in the future. Let's look at how it happens. So in order to dig a little deeper, let's take the same case study about the Northern California ACO that Grant introduced earlier. They worked with us to create a best-in-class care management model which was truly collaborative, that involved disciplines and members across settings, including the hospital, as well as community-based organizations and post-acute organizations like skilled nursing facilities, home health organizations, and even the safety net community clinic. Once they built this model, they created the process that you see a snapshot that Grant introduced you to earlier, and we were able to configure that process into a mobile device with the right set of at-a-glance checklists, with the push alert rules configured. What that allowed them to do is to bring an evidence-based hybrid model that was built out of the care transitions coaching intervention that is more popularly known as Dr. Coleman's model, and another complex care management model together with technology-assisted care team coordination, and connect these various organizations simply through the power of mobile devices. So the picture at the bottom right shows you how they constructed their mobile network, where various different disciplines would collaborate using mobile devices to orchestrate the process you see on the left-hand side. Next slide, please. And the results were just very powerful and compelling, that they are now starting to expand this to other facilities, other hospitals across counties that that the ACOs has taken up additional risk for. If you look at the graphs, what it shows you is on the right, extreme right, you see the readmission rates that they have achieved for their high-risk population, which is 10.2%. And when you compare it with the Medicare beneficiary readmission rate, it's less than half. So they have a very powerful story to tell in how a care manager who has been trained in the right evidence-based interventions and process, when they lead a team in the community and collaborate across organizations supported by mobile technology, they can drive better outcomes that helps them achieve their financial goals as well, because they're part of the Medicare Shared Savings Program. So very powerful story to tell here. What's even more compelling here is that the hospital that's participating in that network, as I showed you earlier, was not only able to achieve the outcomes of better readmission rates and better patient satisfaction scores, but they also were able to drive down length of stay through a better connected, more coordinated team. They were able to plan their transitions early, right from the time of admissions, make the referrals, get all the patient preparation done, because the technology just gave them an instant view of which patients needed to be discharged when, what interventions needed to be done for whom, and people were able to get better organized around the goal of the discharge date that was collaboratively decided across that team. All this improvement in the process meant that the clinicians didn't have to spend time chasing around other people looking whether certain tasks were done or trying to find who was on the team. We measured almost a 60-minute savings per shift for the attending physicians, the hospitalists at that facility. And what's something to be taken away from this slide is that it's the right thing to do for the patients to improve readmission rates, improve patient satisfaction score. There's no doubt about that. But if you need people, providers, and organizations to take on additional work, we have to make a financial difference for them. We have to provide solutions that also address the efficiency. And because we were able to achieve both, the program becomes sustainable. Because otherwise, burnout, variance in processes, drop in adoption rates can quickly put such a program in jeopardy. We also saw other process measures improve significantly, which contributed to those outcomes. A very telling number is the 30% increase in follow-up appointments that were scheduled with the safety net clinic for patients who didn't have PCPs. With the touch of a button, the inpatient case management team was able to notify the clinic coordinator about a patient's need for a follow-up appointment, say 3 days post-discharge. If that information was not delivered to that coordinator in time, oftentimes they may not even make the appointment. The patient may have already been discharged, and we've all seen studies that say if the patient is involved in making that appointment prior to discharge, the likelihood of them keeping that follow-up appointment is much higher. So that 30% number has a big effect on their patient satisfaction as well as readmission rates. The 40% increase was in referral into this post-acute care management program that Grant described earlier. Obviously, if you're not able to, if you put the best process in place, but if you're not able to coordinate it in a manner that you catch the right high-risk patients and bring them into the programs, then all the work is for naught. And by driving this increase in referral, they were actually able to get a return on their process improvement investment with this care management model. On the right, you see readmission rates specifically for care management patients, very powerful number. The rate at which they identified medication discrepancies and were able to intervene to address that discrepancy when the patient had already gone home. 40%, astounding number, hard to prevent, but it's very important that you identify that existence of that discrepancy and intervene before it can result in an avoidable ED visit or a readmission, and they were able to achieve that. And last but not least, the number of patients discharged earlier led to a sustainable process for the hospital and definitely satisfied their CFO to keep the program going and expand it even further. Next slide, please. So before you consider a solution that can help you achieve similar outcomes in terms of better care at lower cost, what are some of the points that you should look at whether a solution like that has? There are many solutions today out in the market about that provide just a secure texting capability, which is nothing better than a secure way of using SMS. So that may provide a solution to the risk issue, but definitely doesn't give you a sustainable approach for quality of care improvement or efficiency of process improvement. What we need to consider here are, does the solution support patient-centered messaging so that the provider doesn't have to keep typing? I have a question about patient Joe Smith in room number 5601 and have to keep setting the context for each patient. If the messages are within the context, then efficiency of communication is significantly improved. So patient-centered messaging would be a key one. Can the messaging solution connect a multidisciplinary and cross-continuum team? The survey results clearly, all of you agree that connecting this cross-continuum team is the key to solving this problem. So you need to figure out, can this solution really span across settings and connect a multidisciplinary team? And it has to do so within the context of a patient, within the context of the role each member of that team is playing for that patient. Because as in healthcare, nobody can say that a particular person is the person to be reached, but people are always trying to reach the case manager for a patient or the home nurse of a patient. So it's the role and the association that's more important. And that solution, as the third question highlights, needs to be aware of that clinician's role so that the messages can be routed to and the interventions can be routed to the right provider at the right time. We have talked at length about the need to bring in and improve this process by leveraging evidence. What has shown to work in trials and across organizations across the country, and there's a lot of evidence that has been published in literature. Can you bring that in and configure your solution to incorporate that evidence? Without that, you will be shooting darts in the dark, blindfolded, and it's at best a crapshoot to try and achieve a particular outcome. If you have all of these, then we can strongly say that the solution can address not just the strategic clinical priorities for the organization, but also their financial priorities. Because, as I mentioned, for it to be sustainable, not only have we to help deliver better care, but we have to improve the cost of delivering that care as well. Next slide, please. So how did we do this? Zinc's Carebook is an example of such a solution that is mobile and completely wireless enabled, so that you can, with very low cost and very low ramp-up times, connect providers across organizations so that they can now start collaborating in real time, messaging in real time, in a role-based, patient-centered, contextual manner, and capture evidence that has been shown to work in studies across the nation, so that you're implementing a best-in-class process that works for your patient population, that works for your organization, for your network. Next slide, please. Once we have built this network, connected with various organizations, the transitions of care and referrals into care management become almost seamless. The team in the hospital is connected all the time, and as they collaboratively assess the risks and the barriers to discharge for patients, Grant had talked about this funnel that brings in, selects key individuals who are at higher risk for readmissions or adverse events. And this process helps collaboratively target those patients, refer them into the appropriate care team resources that may be in the community, all in real time without having to even pick up the phone with the touch of a button, and navigate those patients to the right mode of care, the right pathway. If they are low risk, perhaps the process calls for a series of follow-up phone calls over the month post-discharge. If they are a high-risk patient, it is probably more effective to have someone follow the patient home for a period of time and make sure that they are doing well. So a home care nursing approach may be more appropriate. Whatever be the model or the evidence, we can help you with Zinc's Carebook to build the process and get that implemented with a very efficient approach. Next slide, please. A couple of use cases that will show you how once this network is in place and the process and people are now connected, how a patient care can be impacted in real time. What you see here is a situation where a patient, perhaps an ACO patient, is in the hospital. There's an assessment being done either by the case manager or collaboratively by the team that highlights a couple of key barriers to this patient's discharge that indicates this patient doesn't have the right social support if they go home, and they have limited transportation, which implies they may be unable to go for their follow-up appointments or pick up their medications. What this means is evidence says that they need to be assigned some type of a support once they have left the hospital who can help address that social need, address that transportation need. In this case, a rule can be configured that automatically notifies a social worker. That social worker could be a hospital employee, it could be a community-based organization, and they would instantly get an alert that you see this green bar on the screenshot on the right with an audible notification that says, patient's going to be leaving in 2 days, they need home support, please come by or call, see the patient, talk to them, and see how you can assist them. That real-time notification is very powerful in bringing and constructing the right team and making sure that that care can be and that patient engagement can happen before the patient leaves the hospital. Here's another example of that same power, but in this case, the patient's already been discharged. Being a high-risk patient, our system has assigned a home care coach to that patient, and the patient's being visited by this coach. The home care coach asks the patients to bring their medications to the table, and in the shoebox uncover several medications that the patient perhaps should not be taking or is not clear. With the touch of a button, she now invites a transition pharmacist into the team. The pharmacist is able to collaborate in real time, message with the home care coach, and if need be, put in a call to the patient to ask to discontinue those meds, and if need be, set up a series of follow-up phone calls. What that means to the patient is real-time intervention to prevent what could have been an ED visit if those medications were to cause some adverse event for that particular patient. So that's the power of a real-time intervention and how it can actually change the care for a better approach. Next slide, please. So I hope with those two use cases, we have completed the third leg of this three circles that Grant introduced us to, which is making sure that the right people, the right process, and the right technology can be combined to make a very powerful care transition model, care management model that is going to be required in this new world to not only achieve better care, better outcomes for the patients, but also reduce the cost of delivering that care. Thank you very much. Any questions, please?
Okay, we'd like to open it up for questions. As a reminder to the audience, use the questions in the console of the GoToWebinar box on your screen. Okay, we have several questions. The first question goes back to the beginning of the presentation where you talked about the polling questions. They want to know what data provided the 80% of medical error statistic.
That source is the Joint Commission, and we can get you the actual detailed citation, but it is the Joint Commission accreditation organization findings based upon root cause analysis of sentinel events.
Okay. Here's another one. How can a hospital not affiliated with an ACO improve their care transitions? Is there a role that can serve the function of an ACO care manager?
Absolutely. So the care managers are basically case managers, as you all know, but their role has been slightly repurposed to follow the patients after the patient has been discharged. So in several of the hospitals, we've seen exactly this. The question is they're not formally involved in any ACO, but they have designated one or two case managers from their inpatient side with additional responsibilities, or perhaps repurposed responsibilities that says once the high-risk patients have been identified prior to discharge, their job becomes following those patients and maybe making phone calls and referring them to the right providers through CareBook in order to provide that safety net for those high-risk patients after the discharge. The reason it makes sense for the hospital to do this is it is cheaper for them to even add one or two personnel to address this high-risk discharge than it is for them to pay the penalty of a readmission penalties or be targeted for other penalties because of value-based purchasing or not meeting certain quality measures. With the new world of bundle payment and capitation rapidly approaching, this is a worthwhile investment for hospitals, even if they're not involved in ACOs.
This next question has multiple parts, so I'll pose the whole thing and then you can address it. How did the ACO implement their improved care transition process? Was it phased? Was it all at once? How long did it take from planning to fully live? And what are they planning to do next?
So in essence, it was more or less a big bang approach, but with first off, in understanding who all was involved in the care transition model, both at the acute inpatient side and then outpatient, and then designing, in essence, the workflows associated with the communication activities that would occur either outside in the community or within the four walls of the hospital that would then notify the care managers as patients from the ACO entered through the emergency room or through a planned admission, and then when they were transitioning back out into the community. The overall implementation time in order to establish workflows, identify roles and responsibilities, and then test the infrastructure itself took approximately 8 weeks or 2 months.
And to clarify, obviously the organizations such as ACOs and hospitals are under time pressure to get these models running, because every day they delay is more potential readmissions and other adverse events that are occurring. So we have a very strong consultative process. 40% of the Zincs Health organization are clinicians, so we help consult and guide the organizations on how to achieve this change as rapidly as possible.
The important thing is to really simplify the model as much as possible. So, for example, we have another organization that was not included as one of the case studies where they're doing a phased approach, where they're starting with a certain subset of clinicians, primarily physicians or mid-level providers who are using messaging, alerting, and risk notification or risk stratification to support the consult model. But phase 2 will expand now to case management, social work, and other clinical leaders involved in care transitions. And phase 3 will be a broader organization-wide approach where all clinicians who are touching the patient directly and indirectly will participate in the CareBook model. So there's no right or wrong answer. It really depends on the organizational goals or the shared goals. In this case, the ACO and the hospital had a very clear shared goal, and therefore wanted to create a very simple model which expedited the deployment process.
Can you tell us how communications are directed to the right person? Does someone triage them?
It's a combination of both individual and role-based communication. So, for example, when we were talking about how individuals are brought to a team, typically an individual can either pick up a patient based upon their role and their responsibility, or they can be assigned a patient. And then as those roles or those individuals in those roles change, those are the individuals that would receive messages about that particular patient. So, for example, a case manager might work Monday through Friday, 8 to 5 p.m. And so the role and the person would never change, and messaging associated with that person, there are use cases based upon what's appropriate to message when. However, an individual providing direct care, a staff nurse, a hospitalist, an intensivist, they obviously transition during the course of a day as they change shift. And so although the role is still associated with the clinical care of the patient, the individual in that role now changes, and they would receive the appropriate messaging associated with the care of that patient.
Back to the use case for the patient with barriers to discharge, what workflow process for the social worker supports removal of that barrier? And does information regarding the lack of social support at home come from the social worker's entry into the EHR, and from the EHR to what application?
And the answer is possibly yes, depending upon the workflow that's been identified. And this brings us once again back to, all roads lead back to Rome. Rome being really clear identification of what are the processes associated with care transitions. In other words, who's involved, what data do they collect, and where does it go? By extension then, and I want to reiterate, the source of truth is always going to be the electronic health record in terms of, various elements of documentation. But it may be that we've identified either using RED or BOOST or Coleman that there is some either individual or combination of barriers or risks that when identified will automatically trigger then within the application notification of a particular individual. So where we identified whether or not there was the appropriate social resources in place in the community would really depend upon who is assessing and documenting what within the electronic record. For example, a nurse might, as part of the admission of the patient, identify a particular issue, or not, as the case may be. It may be that in some organizations they have a more formalized, what we call case management, social services, care management discharge readiness model, where they would go in and as part of their routine practice, based upon risk stratification, do a more detailed analysis of what the social determinants of clinical need or care are. And so once again, it really depends on what we can tease out of an organization in terms of what they do and what their current workflow is and what they would like it to be.
And if I may add, I think the very question, which is a very solid one, indicates the level of complexity and dynamic nature of patient care today. Because we all know that it's never the same role or same person who's going to have all the information. Information can come from various venues, from various sources, and we have had cases where the care manager who knows the patient is much more familiar with the patient than an inpatient case manager who may only see the patient for those 4 or 5 days, has more information. The key is how can we make sure that the right people are connected so that the people who have the information can share it with the others in a timely manner. That's the essence of the solution that we have put together, is the timeliness of bringing this team and in a manner almost crowdsourcing the right information from a set of people who know this patient in various aspects, and using all of that to form a complete picture of all the patient's barriers, risks, then give back to that team a set of interventions that they need to now carry out to keep this patient safe.
Yeah, and if I just add one more thing, I think the person who's asking the question is probably suggesting that could there be some kind of connection between the EHR and care book in terms of, okay, I identified this in the EHR in terms of an assessment, and does it automatically now flow into care book and therefore automatically notify someone? And the answer is no, simply because, well, a particular risk factor or combination of risk factors may be identified, they still have to be evaluated within the context of the person and their family to determine, are they significant? Just because I have limited social support doesn't automatically put me at high risk. That may be true in combination with other things, or I'm perfectly capable of managing myself even though I have limited social support. So once again, we're using Carebook as a way to then take those assessment elements and make a determination and therefore more efficiently communicate with those individuals who do need to be brought to the team, as opposed to, for those of you who have experience with EHRs, know that just because I identify a certain element in the chart, the electronic chart, doesn't necessarily always mean it goes somewhere, so to speak.
Okay, we are at the top of the hour. There are many unanswered questions, and a lot of them are specific to the CareBook product and pricing. So for those of you who have posed questions that we have not asked or addressed, the questions will be sent to Grant and Shiva so they may respond to you personally through email. So with that, we'll conclude our webinar. I want Grant and Shiva, it was a great presentation, inspired lots of good questions and discussion. Attendees, watch your email for links to the recording of today's webinar as well as a link to the PDF version of the PowerPoint presentation, and we'll look forward to seeing you at our next HIS Talk webinar. Have a good day.
Thank you.
Thank you.